Good evening, everybody. My name is Ashraf M. I'm a fellow of obstetric and gynecology in Ahwa Teaching Hospital. Today, we will be talking about screening and management of pre-invasive cervical diseases. So, first of all, there is a huge inequity of cervical cancer. Every year, there is more than 660,000 new cases of cervical cancer and 350,000 new deaths of cervical cancer every year. More than 85% of them are in low and middle income countries like ours. So, cervical cancer is the fourth most common cancer in women worldwide. It's a preventable disease. It's a disease that we can prevent, but still women die from it. And the cause is mainly due to most of the cases happen in low and middle income countries with lack of infrastructure and finances to have an effective vaccination and screening program. Although this is changing right now in Egypt, due to WHO initiative and the presidential initiative, we are starting screening program and vaccination programs. So I hope the tide will change soon, but nevertheless, this is the current situation. So first of all, we have to talk about the cervix, the anatomy of the cervix. In brief, we are talking about there is two types of cervical epithelium: the Mullerian epithelium, which is the columnar epithelium, and the epithelium of the vaginal plate, which is the squamous epithelium. And between them, there is the squamous columnar junction, the old and the new, and between them are the transformation zone. So this is a little bit tricky part. This is where most people get confused. So to unconfuse, the cervical canal is covered by columnar epithelium. At birth and up until puberty, the pH of the cervix and the vagina are alkaline. So the cervical canal are covered by columnar epithelium. The portion vaginalis, or the cervical part of the cervix, are covered by squamous epithelium. Between them, there is a squamous columnar junction. At puberty, the estrogen level increase, so the production of lactic acid increase due to the activation of the lactobacilli. So the pH of the vagina changes from alkaline to acidic. So and there is cervical eversion. The cervix open up like a flower. cervix بيفتح لبره زي الوردة. فبيحصل there is exposure of this part of the cervix, which was not previously exposed to the vagina, acidic part of the vagina, and now is exposed. So this was covered by columnar epithelium, but due to the acidic media, it will transform into squamous epithelium. Why? Because the squamous epithelium is almost double the thickness of the columnar epithelium, and it's more bacteriostatic and more resistant to bacterial infection. So now we have two squamous columnar junction. This was the old squamous columnar junction, and this now is the new squamous columnar junction, which is toward the external os. So there is a squamous metaplasia. So this is the cervix. There we have three parts. This is squamous epithelium. It was squamous and will always remain squamous. This is columnar epithelium. It was squamous epithelium. It will always remain it was columnar epithelium. It will always remain columnar epithelium. And this area in between them, this area was columnar epithelium and then transformed into squamous epithelium. So this is what we call transformation zone. So there is a squamous metaplasia here, and squamous metaplasia can very easily turn into squamous anaplasia. So this is why the most common type of cervical cancer is squamous cell carcinoma. And 90% of cases of cervical cancer happens in this area, the transformation zone, where normally, physiological for every female, squamous metaplasia happens here. So a little talk about HPV. I know Dr. Basil covered very well in the previous lecture, but we will just revise a few things. HPV is a double-strand virus. It's a very common virus, very common infection. Although even in Egypt, we are thought to be HPV naive nation. We don't have very much HPV infection. Two studies conducted in Egypt showed that the current actual incidence of HPV infection in Egypt is between 10 to 15% of the overall population. So it's a very common infection. HPV have more than 150 types. Very small number of them, almost 14 types, only 14 types that cause cancer. Most of them are HPV 16 and 18, which cause around 70% of cervical cancer. So HPV infection, most common of infection, it's a very common infection. Most of the cases are transient infection. The persistence infection, this is what increased the risk of cervical cancer. So we have two families within the HPV family: the non-cancerous family, which includes HPV 6 and 11, which cause congenital worse. It doesn't cause cancer. And then we have the cancerous types, which are 14 types, most common HPV 16 and 18. This is a very important table to understand the association between HPV infection and cervical cancer. The HPV 16 infection odd ratio with cervical cancer 435, which means that a woman who has an HPV 16 infection is more likely to have cervical cancer than a woman who doesn't have HPV infection by 435 times. To put things into perspective, smoking increased the risk of lung cancer by only 8. So 8 folds, this is the number of folds that the lung cancer are increased within smoking. In HPV 16 infection, it's 435. This will show you the close association between HPV infection and cervical cancer. So how is the HPV infection cause cervical cancer? HPV, as we said, it's a double-strand DNA. It infects the basal layer of the cervical epithelium. It injects its DNA. Then the infected cells are replicated. Then it go to the upper layer where it sheds. It then transform to cervical atypia, CIN1, CIN2, CIN3. Then it's transformed to cervical epithelium, cervical cancer. So most of the cases are persistent infection. Only with the cases that cannot clear the infection, this will increase the risk of cervical cancer. This process took almost 30 years, 10 to 30 years, 3 decades. This is the time between the first exposure to HPV till the formation of cervical cancer. So cervical cancer, as we say, is a very rare complication of a very common infection. And this is very important to be put in mind when we're talking about screening. So what increased the risk of the persistent infection? Two things. First, increase the viral load or increase the exposure to the HPV infection. Patient who has a multiple sexual partners, or patient who has a partner who has a multiple sexual partners, or early onset of sexual intercourse. Or the patient is cannot clear the infection due to STD infection, HIV, anything that causes immunosuppression, organ transplantation, cytotoxic drugs, HIV, poorly controlled systemic illness, or cigarette smoking. So this is the natural course of the HPV infection. The normal cells get infected by HPV. It takes 1 to 2 years to clear the infection to turn back to normal cells. Most of the cases will clear. Very minor number will progress to CIN1, or what we call LISL, low-grade squamous intraepithelial lesion. Most of the cases will regress. Few will progress to CIN2 or 3, which we call HESL, high-grade serous intraepithelial lesions. Most of the cases of CIN2 and 3 will regress. A very few number will progress to invasive cancer. So this is the natural course of the disease. So we have years from the normal, from the start of the infection till we have invasive cancer. So how to prevent cervical cancer? In order to prevent cervical cancer, we have two areas or two main focuses. First is HPV vaccination to prevent HPV infection from the first place. As we said, HPV is associated with 90% of cervical cancer. So 90 to 95% of cervical cancer is HPV associated. Only 5 to 10% are HPV non-dependent, as neuroendocrine or other rare subtypes. Plus the identification and early treatment of the pre-invasive cervical diseases. So we have CIN1, CIN2, CIN3, these all that we can treat. We can discover the patient here and treat her here to prevent her to go to invasive cancer. So how can we screen for cervical cancer? This is what we call classic screening criteria. This is the criteria that should be available in every ideal screening test. The condition should be important to health problem. We're talking about 350,000 deaths per year, so it's very important. Should be acceptable treatment. For the recognized cases, facilities should be available to recognize and treat, diagnose and treat the disease. There should be recognizable latent and early symptomatic stage, which we do have in cervical cancer. We have 10 to 30 years. There should be suitable tests or examination. There should be this test or examination should be accepted for the population. The natural history of the disease should be well understood, which we do have, and there should be agreed policy on who to treat or who not to treat. And the cost of case finding, including the treatment, should be appropriate. We cannot allocate most of our budget to a disease that causes 1 in 2 or 300 cases. A case finding should be a continuous process. This is it's not just one time I see the patient, then it's lost. No, it's a continuous process. So in HPV and cervical cancer screening, we have two types of screening. We have the HPV testing, or they have the cytology. As we just mentioned, there's an infection with the HPV that causes cellular atypia or cytological changes. So we can either look for the HPV infection, or we can look at the cytological changes in the cytology. We can do either one of them alone, or we can do them both at the same time, or we can do what we call a reflex testing, where we start by one test, then if it's positive, we do the other. I perform the cytology. If it's cytology is positive, I do HPV, or if the HPV is positive, I do the cytology. So how every one of them, each one of them is performed. We have for the cytology, we have two types. We have the liquid-based cytology or the conventional cytology. Liquid-based cytology, the cytology of cytoprush is available or with the liquid-based solution in this jar. We just put this in the cervix, we take 2 to 3 times, then you cut here and put it in this container and then send it to the lab. You do nothing else. This is all what you have to do. And then we have the conventional, we have the iris spatula, and you scrape the external os, the portia vaginalis, the endocervical canal, then you put it on the slide and you fix it with alcohol, then you examine it under a microscope. So which one is better? Both are equally sensitive in detecting precancerous lesion. However, the liquid-based cytology significantly decrease the unsatisfactory smear from more than 50% of the cases in case of conventional pap smear to less than 5%. The sensitivity of cervical cancer of cytology of cancer is only 50 to 60%. Why is that? Sampling and preparation alone responsible for almost 2/3 of the false negative results. The human error of microscopic examination accounts for the remaining 33%. So how to prevent this? With repeating cytology. So as we said, the screening process is not just one time show. No, it's a repeated process. I examine the patient, then I schedule an appointment for the patient to come back. I have a very long natural course of the disease, 10 to 30 years. So I don't just examine the patient once and send her home. No, I examine the patient once and then repeat and schedule a new appointment for the patient to come back. So, and this is the most important slide. The screening is for asymptomatic women. This is the cardinal rule of screening. I'm screening for a disease that is asymptomatic. I'm screening to see if there is a disease that is hidden within the patient. There is no screening for symptomatic women. Once the patient is complaining, once the patient came to the ER, to the clinic, to the outpatient clinic, to whatever, when the patient is complaining, postmenopausal bleeding, postcoital bleeding, abnormal vaginal discharge, heavy vaginal discharge, wherever the cause, when the patient is complaining, then there is no room for screening. I'm screening only asymptomatic patients. Once the patient is complaining, then I should diagnose her and treat her accordingly. So there is no cytology, there is no room for cytology in a case of fungating cervical mass. This is a case for biopsy, not cytology. So what the cytology can tell me, the cytology results can have any of these results. We have squamous cell abnormality, glandular cell abnormality, or other malignant neoplasm. The squamous, we have high grade or low grade. The low grade is ASCOS, which is atypical squamous cells with uncertain, unsignificant or uncertainty. Or low grade serous intraepithelial lesion. ElAsk-H, which is atypical squamous cells where high malignancy, high grade atypia cannot be excluded, HISL, high grade squamous intraepithelial lesion, or actually squamous cell carcinoma. The glandular, we have high grade and low grade. Low grade ElAdrus, endocervical or endometrial. High grade, which is atypical endocervical fibroneoplastic or glandular fibroneoplastic, or actually endocervical adenocarcinoma or adenocarcinoma or other malignant neoplasm. So this is about the cytology. So how about HPV testing? As we said, there are two types of screening. I can use either one modality or both. First is cytology. We just talked about it. Then we are talking about the HPV testing. So the HPV testing, the cytology is subjective. This is one of the main advantages of the HPV. The cytology is objective. It's the pathologist who's looking to the cells under the microscope. He may think this is a high-grade atypia, this is low-grade atypia, but the HPV is objective. It's either positive for infection or negative for infection. It has a higher sensitivity, but a lower specificity. Keep in mind, we're not looking for the HPV infection. We're not trying to prevent HPV infection. We're trying to prevent cervical cancer. So HPV is a very common infection. 10 to 15% of the population in Egypt, which is a HPV naive nation, is currently infected with HPV. So I'm not talking for the HPV. So the actual fact that this patient has an HPV infection doesn't mean a thing to me. This is not what I want to treat or what I want to prevent. I wanted to prevent this patient from having HPV. I would want to prevent her from having cervical cancer. So it's a very high sensitivity but low specificity for cervical cancer. It has a strong negative predictive value. So if this patient doesn't have an HPV infection, it's most probably will not have cervical cancer within the foreseeable 5 years. But if this patient have HPV, so no, I have to put her in a risk stratification system. Increased risk of CIN3, even if this is a negative cytology, and we will talk about it in a moment. It's allowed for risk stratification, and it has the ability to let me detect earlier a high-grade CIN. But always keep in mind, we are trying to prevent cervical cancer. We are not trying to prevent HPV. So what are the challenges of HPV testing in low-middle income countries? Labs are simple. HPV testing is difficult. It needs huge machinery. It needs molecular classification. It needs, as we talked, there is almost 150 subtypes of HPV. So only 14 of them are cancerous. So even the fact that this patient have a HPV infection doesn't automatically necessitate that she has one of the 14 cancerous subtypes. The disposal of the waste fluids and plastic is a major problem. HPV in themselves testing is confusing as we said, and the results are not immediate. And in low middle income country, patient control and the patient follow-up is very difficult. So if I have a patient, I took a HPV test today and said, okay, come back within 1 week to receive the results, then another week to schedule a cytology, then another week to receive the results for cytology, the patient will never come back. We are talking about patients who are low socioeconomic in a low middle income country. Patient follow-up is very difficult. And there's, as we said, there are higher sensitivity for the infection, but low specificity for the cytology and correlation with the cytology. Sorry. So the ideal HPV test in low middle income countries, it has to be easy and acceptable to women. It should be not expensive for the government. It should have high sensitivity and rapid results, allow screen and treat within 1 day, and safe test with minimal follow-up. So this is actually available in 2 machines, the Care HPV and the Gene Expert, which are both available here in Egypt, because these 2 machines are used in the DNA and the sequencing for HIV and the hepatitis B and the TB. So they are available here in Egypt. We will not spend time, or there is some companies provide what we call self-testing. This allows the patient to collect the sample herself at her home at her convenient time. And this is actually available here in Egypt. We will not spend time, or there is some companies provide what we call self-testing. This allows the patient to collect the sample herself at her home at her convenient time. And So I can see the patient while she has a menses. So I cannot have an HPV testing right now. She's currently menstruating. So I can give her the test and say, this is how to collect the test. And you can mail the results to me, or you can give it back to me, or you can stop by the institute at any time to give us your sample, and we will inform you about the results. It's compatible with both the devices, the KHBV and Gene Expert. And in low middle income countries, there is a third test that we can sometimes use other than the cytology and HBV, which is the VIA, visual inspection with acetic acid. It's a very simple test. It's a very low tech, low budget, low cost. We simply dye the cervix with 3 to 5% acetic acid, and we see the whitening change. If there is anything in this any area of the cervix that turn white, aceto white area, then this is an area that should be biopsied. So we put the patient in a certain position. It's an outpatient position. I can use it in opportunistic screening, as we say, a patient who came for contraception, for IUCD, for any examination. I'll just put the patient in a certain position. All I need is a speculum, an acetic acid, a cotton pad or a cotton tip, and a flashlight. This is all what I need. I just paint the cervix with 3 to 5% acetic acid and wait 1 minute. If there is a white area, then this is a suspicious area, then this is an area that should be biopsied for further confirmation of cervical changes. The household acetic acid, the الخل which اللي موجود عندنا في البيوت كلها, this is not 3 to 5%. This is actually 30%. So if you don't have access to industrial level acetic acid, 3 to 5%, then you can use the household or the home held acetic acid, which is 30%. You just diluted 1 to 9. So 10 millimeter acetic acid, 10 millimeter vinegar, to 90 millimeter water or sterile saline or distilled water. It's almost equivalent to the colposcopy in trained personnel. It has 1 minute development. It will only take 1 minute. I can inspect it by naked eye. I don't need a colposcopy. I don't need anything else. Just speculum, flashlight, acetic acid. This is all what I need. But the problem, this is positive. This is acetic acid. This is positive. This is positive. This area is white. This is negative. This is positive. This is aceto white area. This is negative cervix. This is a positive. This cervix should be biopsied. It doesn't mean cancer. It means that this is an abnormal cervix that we should biopsy. This is aceto white area. So what makes it attractive? It's low cost, low tech, one-step screening. The patient will sit on the just in the certain position for 2 minutes. I perform the test. I take the biopsy, punch biopsy, whatever. Then I can tell her to go home and follow up with us within 2 to 3 days. But the quality control is very difficult. So the results are dependent on the physician, on the personnel who's performing it. So it don't have a very reproducible results. So what I can perceive as a aceto white area, Dr. Khaled can perceive as not as his cervix. Dr. Besser can perceive as a suspicious cervix. So the quality control is very difficult, and the inadequate training for personnel make it very difficult. So how, who, and when to screen? First of all, as we said, screening is for all women. Any women who turn 21 should be screened. So we will categorize the entire population into 2 categories. First, the asymptomatic immunocompetent patient. So this is a patient who don't have a chronic medical illness, bony control, who doesn't smoke, who don't have HIV infection, who is not on cytotoxic drugs, who is not on immunosuppressive drugs for organ transplantation. So this group of patients, if they are below 21 years old, so screening is not recommended. We don't screen this patient before 21 years old. Why? Because there is a very high incidence of false positive result. These patients will have HPV infection. This is an age of sexual activity, especially in the Western countries. It's a age of sexual activity. So she will have HPV, but she will not have a cancer. So I will have a very high results of HPV infection. And most of the cases of HPV uh, will be cleared spontaneously. And even 90 to 95% of low-grade squamous endometrium lesion and ASCOS, as atypical squamous cells of uncertain grade, they will clear spontaneously. So we don't screen patients before 21 years old. Patient 21 to 90. This patient, we start the screening process at age 21, regardless of the age of initiation of sexual activity. We perform pap smear every 3 years. We don't recommend HPV in these cases in this age group because all these group will also have high false positive rates. We can consider HPV every 3 years instead of the pap smear every 3 years for patient above 25 years old. So patient from 30 to 65 years old, we can do either one of the three. We can do the co-testing every 5 years, which is preferred. So every 5 years, the patient will come for a pap smear and HPV testing. Then if the results are normal, they will come back in within 5 years, or continue pap smear every 3 years, or consider HPV every 3 years. Patient above 65. Um, we can discontinue the screening after 65 years of age if there is no CIN 2 or 3 within the past 25 years, and there is 2 consecutive negative co-tests, the HPV and the pap smear, or 3 consecutive pap smear within the past 10 years. So if the patient for the last 10 years she didn't have and she have a negative co-test or negative pap smear for the past 10 years, then we can abort the screening process. But if there is any one of these two, if one of these two prerequisitions are lost, then the patient will continue the screening. Some countries like Germany, they continue the screening till 80 years old. So the screening for high-risk women, the high-risk women which are immunocompromised, the HIV, new to exposure to DES, diethylstilbestibol. The patient with HIV are, this is the other group of patients, the patient with HIV, they have a more tendency for persistent HPV infection and high-grade cervical dysplasia. So we start this specific regime at the time of HIV diagnosis, not before 21 years old. So if this is diagnosed at 29 years old as HIV positive, then for the past 8 or 9 years, she was screened as general population. At the time of HIV, no, we switch her to a high risk women. So we start this screening process. So this screening process consists of one of two things: pap smear for every 3 years, pap smear annually for 3 years. So we perform pap smear for every year for 3 years. If the three are negative, then we can switch to, as a general population, pap smear every 3 years. But if one of them is not negative, then we cannot go back to the general population screening. For the patient above 30, either cervical cytology alone or co-testing is acceptable. HIV infection alone cannot be recommended. We cannot perform HPV infection alone, HPV testing alone. We can perform either co-testing, HPV with pap smear every 3 years, not 5, or we can perform only pap smear every 3 years, but we cannot perform HPV testing alone. Screening in this patient's group doesn't end unless with the patient's death. This continues throughout life. Screening for the other population, as we said, screening is for all women, irrespective of HPV vaccination, irrespective of their age, irrespective of their marital states, a divorced woman, widowed, any woman who has been married once and above the age of 21 should have be put in one of these two groups. A patient who has a history of hysterectomy with CIN should continue the screening, even if she had a hysterectomy. If there is a CIN then in her history, then we should continue the screening. If the patient has no history of CIN and performed a total hysterectomy in this age group, we do not perform, in this group of patients, we do not perform screening. But if the patient had a subtotal hysterectomy, which is wrong, we try to avoid it. But if the patient has a subtotal hysterectomy, then the patient should continue the screening. The cervix is still there. We didn't remove the cervix. We will continue screening for cervical cancer. So how we manage the screening results? So the screening results, we will differentiate patients between two groups: before 25 years old and after 25 years old. And every group of them, we will assess the immediate risk of CIN3 less than 4% or more than 4%. So how do you perform that? If there is more than 4% risk of immediate risk of CIN3 plus, so this patient has, there is a more than 4% chance that this patient currently has CIN3 or above, carcinoma or cyto or invasive cervical cancer, then we perform immediate colposcopy and treat accordingly. If the patient has less than 4%, then we perform a recalculation of the risk and re-examination of the patient in 1, 3, or 5 years. So patients who are below 25 years old, we don't perform HPV, we don't perform biopsy. In the age group before 25 years old, there is a very high spontaneous regression for HPV infection, very low risk of developing cancer. These are the women who are targeted to have HPV vaccination. So we are tended toward a more conservative approach. If there is low-grade squamous enteroepithelial lesion of ASCOS with HPV positive test, we repeat the cytology within 1 year. We don't perform colposcopy. If there is ASCOS with HPV negative, we repeat the cytology within 3 years as the routine for this age group. If there is a persistent LESIL or ASCOS for 2 years, we perform a colposcopy. If there is high-grade serous enteroepithelial lesion or ASC-H or atypical glandular cells at any point in this age group, then we perform immediate colposcopy. So this is regarding the patient younger than 25 years old. So the patient older than 25 years old, we have 4 groups. Immediate CIN risk more than 60%, or immediate CIN3 risk 25 to 59%, or immediate CIN3 risk 4 to 24%, or immediate CIN3 risk less than 4%. I know this is a lot of numbers, a lot of confusing numbers, but this is, we're trying to tailor the treatment in order to limit we have very limited funding in our country and all over the world for screening. So we're trying to limit the number that do unnecessary colposcopy, unnecessary biopsy, unnecessary surgery. So we have to risk stratify the patient in order to better to make the most of our resources that already limited. We are in limited middle income country. So I know this is a lot of numbers and this could be confusing, but we will try to simplify it with each other. So the patients who are calculated immediate CIN risk 3 plus more than 60%. So this is a patient I'm more than 60% sure that she currently have CIN3 or more carcinoma or cyto or cervical cancer. So this is a patients. These patients are the patient with HPV 16 infection. If I perform HPV 16, specific genotyping for HPV 16, positive with high-grade squamous interstitial lesion. Or patient that under-screened, patient who has not been screened for the past 5 years with HPV positive, regardless of the genotype, with HISL. So this is a patient who has immediate CIN3 plus risk more than 60%. So we will talk about her management right now. So the second group are the immediate CIN3 plus risk 25 to 59%. Patient unknown screen history, HPV positive with HISL, or HPV positive with AskH, or HPV negative with HISL. And keep in mind, in HISL or AskH, when we do colposcopy regarding the HPV. So the patient with CIN3 plus risk 4 to 24%. This is a patient who has unknown screening history with HPV positive infection with ASCOS, or HPV positive with LISL, HPV negative with AskH. And the rest of the patient are the patient who doesn't have any of these criteria, so their immediate CIN3 risk is less than 4%. So how to manage every one of them? So we're talking about the group of people who are more than 25 years old. So the first group, the immediate risk more than 60%, immediate excision with LEEP. We do not perform colposcopy. We prefer transfer her immediately for LEEP excision. Why? Because colposcopy will most likely not alter the decision. We don't perform cervical ablation because we need actual tissue biopsy to examine to rule out invasive cancer. The exception for immediate LEEP are patient below 25 years old, or pregnant patient, or patient planning future fertility or future pregnancy. So these patients, we can perform colposcopy first, but again, colposcopy is most likely will not alter their management. So the second group with immediate risk of 25 to 40 to 59, immediate LEEP or colposcopy. In this patient, I can either have a colposcopy, or if we don't have colposcopy available, or the patient refuses colposcopy, we can go for immediate LEEP. And according to the patient preference, the exception for immediate LEEPs are patient less than 25 years old, or pregnant, or patient planning future pregnancies. Immediate risk from the third group, the immediate risk 4 to 24%. Evaluation, we don't perform immediate colposcopy. Immediate LEEP, we first perform colposcopy. If HPV positive for 16 or 18, colposcopy. If negative cytology, in this patient, even there is a negative cytology and HPV 16 or 18 positive, we do a colposcopy. We don't say reschedule, put her back on the regular screening. No, this is a high risk infection associated with 435 fold increase in the cervical cancer. So this should not be taken lightly. If there is ASCOS, do reflux HPV. أو repeat the PAP smear in 1 year. The fourth group, the immediate risk is less than 4%. Then this we don't intervene. This is the most of the patient. So this is most of the population. Surveillance with HPV-based testing, the co-testing. The frequency, when to perform the testing, the frequency depends on the 5P risk. So if we have 1 year risk more than 55%, we perform the surveillance every 1 year. If we have a calculated risk between 0.54 till 0.15, then we do the test every 3 years. If we have the calculated risk less than 0.15, then we do repeat the test within 5 years. So we're talking about this is the screening. This is what the first part of the lecture. I know Dr. Khaled will probably kill me, but this was the first part of the lecture. We were talking about the screening. We're now talking about how to treat.
Uh,
So first, the
uh,
colposcopy.
can we take a break for 1 minute or 2 minutes?
Okay. Okay.
There is still a lot of slides, or
No, no, no. I think there we have like 15 minutes remaining.
really the first part was very, very, very interesting. I think it will provide us with a lot of MCQ questions for our fellows.
Thank you. I hope they don't hate me for it.
Great, great. Uh, if anyone want to ask some questions now, we have here Dr. Sahar have 2 questions.
Okay, thank you, sir, for the informative lecture. I have just two queries. I'd like to know this algorithm, is it an ESGO or an RCOG, or it's an American? I don't know about the.
It's all of them.
Okay,
It's mainly based on the
all
RGCS
of them.
recommendation. I took the RGCS pre-invasive certificate program, so this is mainly dependent on the RGCS recommendation plus the RCOG recommendations.
Okay, the other question, please. How can we calculate this percentage? Is it an app program, or are there specific scores? Or thank you. Thank you so
No,
much.
this table is the score. So this is a table. This table is the actual score. So if the patient has HPV 16 infection, with this put her immediately in the immediate CIN risk more than 60%. So if the patient has any of this is the calculated risk automatically. So we don't have any more data to input. If the patient has, for example, HPV 16 infection positive with HISL, this is a patient who has immediate CIN3 or higher, more than 60% risk. So this is a patient for immediate leap. This table is the risk stratification. And this is the risk stratification for the patients when with less than 4% risk, when to perform the surveillance within 1 year or 3 years. So if the patient is HPV positive, with NILM, no intraepithelial malignancy or unknown history, this patient we with HPV positive test, then we can automatically have 5 year risk of CIN3 plus more than 55%, but less than 4%. So we should repeat the surveillance within 1 year. We should repeat the HPV based testing, the co-testing within 1 year. If the patient is HPV negative with negative cytology, or HPV negative with nil, then we should repeat the test within 5 years as the general population. This is the actual risk stratification calculator.
Okay, thank you. We can continue, Dr. Ashraf.
Okay. Very few talks about the colposcopy. The colposcopy is a light microscope, magnification used to magnify the tissue. The magnification power is 3.5 up to 30x. It's the gold standard diagnostic tool for diagnosing CIN. It's the diagnostic tool that we use to look as visual inspection of the entire transformation zone, entire muscular junction, the vagina, the upper vagina, the cervix, and even the vulva. We talk about when which patient should be performed colposcopy, which patient should be will be transformed deep. But the contraindication of colposcopy is active cervicitis. The patient has active cervicitis or is on anticoagulant or bleeding disorders, or a patient pregnancy. The pregnancy itself is not a contraindication for colposcopy, but there is a very difficulty in interpretation of the results. And the colposcopy, as we see, is like laparoscopy. It's an endoscopy. It's a light microscope. We are looking at the tissue. So the trained personnel is interpreting the data. There is no marker that says this is high grade, this is low grade, this is cervical cancer. It depends on the personnel eye. So it's very difficult to interpret the data within in the pregnant population. So most guidelines recommend the pregnancy is a relative contraindication for colposcopy. There are multiple types of colposcopy. Every big company provide one. There is one where you look directly within the oculars, and the one who has attached screen. There's one who can who have multiple screens. So there's different types. So in order to understand the colposcopy, they have four fundamentals of colposcopy. You have to understand, you have to see, you have to diagnose, and you have to treat. First, you have to understand the HPV and the cervical cancer, and you have to understand the anatomy of the cervix. Then you have to know the colposcopy. You have to be familiar with the equipment, with the machine. You have to be familiar with the colposcopy techniques. Then you should diagnose. You should be able to diagnose what you're seeing. Then you should be able to use the colposcopy to actually treat the patient. As we always say, before you diagnose, you must be able to see. It's an instrument. It's not a magical tool. It's just an instrument at your disposal. Because most people sometimes talk about colposcopy as some kind of a legendary device, or it's a very simple device. You should understand the woman's emotion. You should watch your language. You should watch your gesture. You should know the environment is privacy. This is a very delicate situation for the patient. You should be able to perform your technique as gently as possible. You should consider your manner. You should consider your language in order to be able to gain the trust of the patient and be able to understand the patient and be able to let the patient you treat her. So how to perform? Basically, this is a very quick. The colposcopy should be placed 3 centimeters from the target tissue. We start by looking from the cervix toward the vulva. We start first by white light, very low power settings to have a global view of the entire area. Then we start by dividing the process into 3 main processes. First, we gross visualize the vulva, the cervix, the vagina. Then we expose the cervix and the upper vagina. Then we perform the biopsy or endocervical curettage as indicated. So there is 2 types of colposcopy vision. First, the gross vision, we look as we look in the naked eye just with a microscope. So we have a 3.5 up to 30 magnification, but we don't apply any special filter, don't apply anything. We just look by our naked eye to see if there is a cervical mass, if there's a fungating mass, if there is anything. This is the most important part. This will decide, you can abort so many procedures if you just have a broad looking of the global view of the vagina. Then you perform the colposcopic examination, the colposcopic examination, the Ludwig iodine, the acetic acid, the green filter to look for specific things that we will talk about. So first, before the gross visualization, if there is any mucus or blood, we remove it by cotton soaked in saline. We don't use disinfection. We don't use any betadine. We just saline. Look for erosion, ulceration, irregular surface, exophylitic growth, leukoplakia or pigmented lesion with your naked eye, with the eye within the microscope. No special filters, no green filter, no Ludwig iodine. This is the first step. The second step is you have to be able to see the entire transformation zone as squamous columnar junction. You have to be able to see it entirely. Then the first step in the second part of the examination, the colposcopic examination, is the colposcopic visualization. The colposcopic visualization, first you apply the acetic acid, like the VEA, 3% acetic acid. The idea of the acetic acid dehydrates the cells, so the squamous cells with relatively large nuclei will appear white. The metaplastic cells, the dysplastic cells infected with HPV, they will reflect light, they will appear white. So this is what we call aceto-white areas. The development of aceto-white areas take 1 to 3 minutes. If there is no lesions, then are we seen with the acetic? If there is a lesion, then I see with acetic acid. So this is a lesion that I should biopsy. So no other visual, no other process should be repeated. So if I see acetic acid, aceto-white areas, so we start by here, take a biopsy. So if there are no lesions by the acetic acid, we apply diluted Lugol's or Schiller's iodine. The glycogen containing cells, I would say the top layer of the squamous columnar junction, the area that was columnar and then transformed into squamous, the top layer are glyconated, so it contained a lot of glycogen. So the glycogen containing cells, which is the superficial layer of the transformation zone, will take the iodine and become dark brown. Non-glyconated cells, which are the normal columnar cells or high-grade lesions, will not take iodine and remain yellow. So when we put the iodine, we look for the yellow parts. The normal parts are the brown parts. The yellow parts, these are the abnormal parts. It's either columnar cells in the transformation zone, which doesn't belong here, or it's high-grade lesions. The location of the abnormalities should be should be noted as a clock, face of a clock, 2 o'clock, 10 o'clock, 8 o'clock. Colposcopic finding themselves are not diagnostic. As we say, the colposcopy is just a method of examination. It's not a treatment. It's tell me where to take a biopsy if I need to take a biopsy. There are no colposcopic findings pathognomonic to cervical cancer. There is no single sign that I can see and say this is cervical cancer. Even if I say if I'm getting this by naked eye, I say this is most probably cervical cancer, but I have to take a biopsy to determine the size, the type, the histological type, the histological grade. Abnormal colposcopic finding to choose the site of the biopsy. I only use the colposcopy to choose where to take the biopsy. And this is very important to determine the depth of the lesion. So in some cases, we talk about in the treatment, in some cases that there is no, if the lesion is extended into the cervical canal, I cannot perform ablative measures. So what are the findings that we can see? Aceto-white lesions, which have borders, they're suggestive of high-grade lesions. Aceto-white lesions with diffuse border, this suggests low-grade lesions. Abnormal vascular pattern, what we call mosaicism. The mosaicism is within aceto-white area suggests CIN. Punctuation within aceto-white epithelium suggests CIN. Atypical vessels suggest microinvasive or invasive. The inflammatory changes are very common to be mistaken as high-grade lesions. If the cervix appear inflamed, then you should test for gonorrhea and chlamydia and treat the patient empirically with a single dose azithromycin before the colposcopy. If the test is positive, further treatment is required with the gonorrhea. So this is the feature that are suggestive. Again, there is no colposcopic finding that is pathognomonic for infection. There is no colposcopic finding that is pathognomonic for cancer. I cannot see a lesion and say this is cancer. I can see a lesion that say this is most probably a low grade or a high grade. This should be biopsies. It should not be biopsies. This is all what a colposcope can tell me. The final saying is for the pathologist, not the colposcopist. So, feature suggestive low-grade disease, we have thin aceto-white epithelium, irregular geographic borders, fine mosaicism, fine punctuation. Feature suggestive high-grade disease, dense aceto-white epithelium, a rapid appearance of the aceto-white, curved crypts, which is the gland opening. You see there is an opening, small opening in the cervix. This is curved crypts. We have coarse mosaicism, we have coarse punctuation, we have sharp borders. Feature suggestive of invasive cancer, typical or atypical vessels, fragile vessels, irregular surface, exophyletic lesion, necrosis or ulceration, or tumor, actually, let's see if I'm getting cauliflower man. Non-specific finding like leukoplakia, keratosis or hyperkeratosis or erosion, this is non-specific. So this is thin aceto-white epithelium. You can see there is a very fade white area here. This is a thin aceto-white. This is a dense acetoide. The final pathology showed Hessel with CIN3. The cytology showed Hessel. The biopsy showed CIN3. This is a normal branching vessels. It looks like this one looks like a tree. This one looks like a root vessels. It looks like a tree. This is a normal vessels. This is a normal vessels. This is fine mosaicism. The final pathology, histopathology is normal. This is a coarse mosaicism in background of a dense acetoide. The histopathology is squamous cell carcinoma. This is a fine punctuation in this in flame cervix, which calls a strawberry appearance. This is an infection. This is coarse punctuation in acidic area. This is final pathology showed squamous cell carcinoma. So how to treat, again, the colposcopy is not, it's like the laparoscopy. You have to see many patients in order to develop your eyes, in order to be able to define and to train your eyes to see. It takes time, it takes effort. This is just the a road map, or just we're trying to يعني نفتح كلام زي ما بنقول كده بالبلدي يعني. So in order to treatment, we have two types of treatment. No should, as we said, no patient should be offered or receive treatment, abnormal pap smear HPV without diagnostic procedure. We have to diagnose first. No, I cannot rely on cytology alone. I cannot rely on HPV alone. As I said, the HPV and the cytology are just screening for asymptomatic patients. When the patient is actually complaining or the screening showed abnormal result, then we shift for diagnosis by colposcopy and biopsy. Then we offer the patient treatment. We don't jump for treatment, except for one case, HPV-16 infection with Hessel on cytology. Then this patient, this is the only patient that we offer immediately leave without colposcope in a patient above 25 years old. So we have two main types of surgical treatment. We can either ablate the lesion or we can excise the lesion. We can remove the lesion, is an intake, and send it for histopathology when I need the histopathology. Or we can have just ablation. We can evaporize the patient, evaporize the lesion, sorry, or just destroy the lesion. So the principle of surgical treatment, as any surgical treatment in anywhere in any part of the world, in any part of the body of the patient, you have to know the anatomy, you have to know the disease, you have to be able to perform colposcopy and map out the disease to know the exact location of the disease, the relation to the internal os. You have to be able to see the entire disease and biopsy the entire disease. You have to make the patient and to take an informed consent, the patient should be know about the failure rate and should know about the effect on physical mobility and psychological mobility and the effect on the future future pregnancy. So aim of the treatment is removing or destroying the tissue. For CIN, we have to go to depths of 7 millimeters. We have to have a clear surgical margin. So we can either remove the entire transformation zone or we ablate the entire transformation zone. So the this in cases this is not very important. We have tight on time. So okay, so in the this is general instruction for any patient that should be informed. The patient should be informed that abstain from sexual intercourse for at least 4 weeks. The patient should be expected heavy, mild or moderate pain for a couple of days. Patient should be informed that after the treatment there will be light bleeding. The patient should be able to contact you or come immediately if there is a fever or there's more than 38 or shaking chills or severe lower abdominal pain or foul smelling or pus-like discharge or heavy bleeding. This is the effect of the treatment on the pregnancy outcome. The effect, this is why we should, this slide is why we are talking about there is no patient should be treated without a diagnostic procedure, because This is the largest Cochrane review. It included 69 studies on 6,357,823 pregnancies. Number of patients who treated was 65,098 and 6,292 and 725 that were without treatment. So there was significant increase in the risk of preterm birth, premature preterm rupture of membrane, low birth weight, NICU admission, prenatal mortality, not morbidity, prenatal mortality. So the treatment affect the patient, affect her future fertility. So we should not jump to treatment without confirmation first. So there are two types of treatment. We are local destructive, the cryotherapy, the cold coagulation of laser ablation, the excision technique, leap or leads, cold knife or cone, needle cone, laser cone. They are all the three. They are equally similar. No one is superior to the other. However, there are very few requisition for every. The when we are performing the colposcopy, we should be able to tell the type of transformation zone, tell the size of the lesion, any suspicious of microinvasion, the patient age, parity, comorbidity, history, previous treatment, probability of patient returning, the ability for the patient to follow follow up, the facilities available, the operator skills, the experience, the equipment available, other expertise available, anesthesia theater. This is all I should consider before telling the patient what is best for her. The ablative, this is the ablative treatment, as we call the cryotherapy or the laser ablation. We destroy the tissue. This is a strict criteria that should be met entirely. All 8 of this criteria should be met. First, the entire lesion should be located on the ectocervix. No extension to the vagina, no extension in the endocervix. The entire lesion is visible, does not exceed 2 millimeter into the endocervical canal. The entire lesion can be covered by the largest ablative probe. There must be a biopsy or histological confirmation that rule out high-grade CIN. No cytological, colposcopic, or histological evidence of invasive cancer. Lesion is not inside the cervical canal. Well, endocervical canal looks normal. Good compliance for post-treatment. And the patient is not pregnant and no evidence of PID. So this is the cryotherapy. The cryotherapy, this is the probe of the cryotherapy. We freeze the tissue and then let it thaw. This it has less pain, but it's require gas, large heavy tanks, difficult to ensure regular supply of the gases. So we rapid freeze for 3 minutes, then slow freeze for 5 minutes, then rapid freeze for 3 minutes, then slow for 5 minutes. This cycle decrease the temperature up to negative 65 to 85 Celsius. The thermal ablation is equivalent. The laser is also equivalent. This is the leads or the leap. The leap or the leap is loop excision electrosurgical procedure where leads large loop excision of the transmission zone. It's simply a loop that we perform, that we transform currency within it. Then we have a one path. Here we cut the entire transformation zone in one pass. This provides us with a tissue biopsy that we can actually send to rule out invasive disease, to rule out high-grade lesion, to rule out the any other associated conditions. And in the same times, the main it's much easier. It needs less training. It's much easier to perform. It needs less surgical equipment. But the main problem, it has the slightly worse impact on the future fertility. And the main point here is two things that I'll just wrap things very quickly. The cone that we take, the rule should be one pass, one cone. So that we should choose the diameter of this This is the we should choose the diameter of this, which one of them to be used based on the size. If there is a very large lesion that we cannot have in one pass, then we should have it in three passes. We use the largest available one. We should have three passes like this. We go 1, 2, 3, and the most importantly, they should be put together uh, uh, before sent to the pathologist, and they should be numbered or should be marked the first, the second, the third, for the pathologist to be able to recreate the lesion or to examine the lesion. The second, there is the Libra leads are not available, very much available here in Egypt. So I think in Mansoura, Dr. Rafiq Babakat, they developed what we can call the homemade device, where we use a diathermy electrode. You curve the tip of it to be like this, or you use a 16 or 18 gauge spinal needle as a curve and put it in the diathermy slide. This is what we're talking about. This is the three passes. And very importantly, you should alert your patient after treatment that if she has a fever, أنا خلصت خلاص. This is the last slide.
Okay.
You should inform the patient if fever 38 or more, or heavy cramping not responding to ibuprofen, or foul or pus-like discharge, or heavy bleeding, she should come back immediately. She should expect diffuse watery discharge for 3 to 4 weeks, but not bloody discharge. So this is what. Thank you. We have concluded the lecture. I hope you enjoyed it, and I'm ready for if anyone has any questions.
Thank you, Dr. Ashraf, for the very informative presentation. Do we have any questions from the audience? I think not. Do you have any questions from our audience here? Yeah, Dr. Amr have a question here.
شكرا دكتور اشرف على المحاضره.
نعم.
منه اللي هو الاكسترنال تكنيك بس I have a positive margin. I should repeat excision ولا there another option of treatment?
According to the pathology. According to the pathology of high-grade lesion, of low-grade lesions, and you perform, the rule is to have ablative treatment. So if you have excision, then you are performing excision because you're afraid of high-grade lesion or invasive carcinoma. So according to the biopsy, the pathology report, if the pathology report says this is a low-grade lesion, then you can have a follow-up. If it said there is there's a high-grade lesion, pre-invasive, we are talking about a pre-invasive, not actual cancer, we are talking about a high-grade pre-invasive lesion, then you can repeat the surgery, repeat the biopsy again. If the pathology said no, this is an invasive cervical cancer, no, you treat it as early stage cervical cancer with either loop, trachelectomy, radical, simple, vaginal, wherever. So you wait for the pathology. You're performing excision because you want pathology. You want an actual tissue specimen to be examined by the pathologist. You are suspecting something. You understand me?
It's clear. It's clear. I have another small question. Do we have an active medication for the HPV? If the patient
medication, no.
Or treatment for the HPV? No.
Medication, no, there is no treatment. There is no active treatment for HPV. Most cases of HPV is spontaneous regression. So there is no one is trying to treat HPV. Mostly, it's like the flu. No one's trying to cure the flu. The flu is just, it's transient infection. The progression of the persistence of the infection, this is what causes cervical cancer, not just the infection itself. So there is no, to the extent of my knowledge, there is no active even trials for treatment of HPV. We're just talking about, because HPV alone is not an issue. We're trying to prevent cervical cancer, so we are screening for cervical cancer. If the cervical cancer is positive, if there is pre-invasive disease, then we treat it. If there is cervical cancer, we treat it, and we try to prevent the infection by the vaccination.
Dr. Ashraf, thanks for the lecture. I just, my question, I'll just take you back to the beginning of the lecture when you were talking about the screening for HPV high-risk patients. And you said in effect down either it regresses, like you said, or it progresses to CIN1 and then regresses, or CIN2 and regresses, or progresses to cancer. Type, and how long does this take? Is it 20 years, you said, or is it 10 years?
10 to 30 years.
So
From the infection, the infection almost take 1 to 2 years to clear. So the patient is infected today, it will take 1 to 2 years for her to clear the infection and go back to negative HPV. It takes, if the patient progressed to CIN1, it takes almost 10 to 30 years to develop from CIN1 till invasive cervical cancer.
And the HPV-16 remains in the cervix till then.
And the cervix, yes.
Yeah. So if I examine her every 3 years or whatever, or every year, because you test after 1 year, and it's still there, then I'm thinking of it's going to progress to cancer, and it will take 30.
No, I will take cytology. If there is HPV-16 infection, if you have, there's 150 subtypes of HPV. So if you're talking about HPV as a whole, just HPV, most of the lab equipment don't perform the genotyping of the HPV. It's very difficult. It's very expensive to perform it as a screening program for the entire population, to screen every single woman in the population, from above age 21, to screen her every 3 years. To do this, it's very expensive. So we do an HPV as a whole. There's 150 types of HPV.
Yeah, I understand.
Only 14 of them cause. So if you are in a country or in a place that we can do genotyping for HPV-16 infection, then you will already permitted the co-testing. Then you perform HPV plus cytology. So you already have a cytology that tells you. So if you have an abnormal cytology with HPV-16 infection, then you are probably increase the risk of CIN3. So you should have a colposcopy, and if you have a colposcopic finding, you should go for LEAP.
Okay.
But if you're talking about generally this patient is either infected or not with HPV as a general, no, you follow the risk stratification for the patient. But HPV-16 infection, specifically with HISL, high-grade serous intraepithelial lesion, this indication for immediate LEAP. We don't perform colposcopy. We have LEAP, not ablation. LEAP to obtain an actual tissue biopsy, because this patient has a 60% chance or more of having at least CIN3. So she can have CIN3 or CITO or invasive cancer.
I think you have a question from the audience. Dr. Wael, I think you can talk if you want.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
دكتور شكرا خاص على المحاضرة الجميلة. لو سمحت عشان يتغير من CIN لهاي جريد لانفيزيف او لريكارنت، الانسيدنس بين دي وديت، وايه الاوبتيمم بعد الاوبتيمم مانجمنت، وايه المفروض اعمله لو حصل سواء ريكارنس لCIN او لانفيزيف.
سكريننج بروجرام. ما عشان كده احنا قلنا السكريننج is not one time. الانسيدنس بتاع العيانين most of the cases are regress. So this is why we perform co-testing. This is what is recommended for co-testing HPV plus cytology. I should be able to understand the condition of the infection, if this patient is currently infected or not, and to have if this infection has already caused cytological changes or not. So this is why it's the preferred co-testing every 5 years. So I'm performing the co-testing every 5 years. This is a screening for asymptomatic patients. If the patient is already having an HPV infection or have a cytology, then this is a patient that we will take out from the screening line. This will not be from the screening cohort. This will be for the treatment cohort. This will be a group of patients that I will follow and treat. And this patient for follow and treat, we have, I can show you the, where is it? Yep.
Okay. Thank you, Dr. Ashraf. Do you have, I think Dr. Wael also want to say something or not?
Yes.
Dr. Wael?
Okay. I'm listening.
Yes, I'm just sharing my screen again. So if the patient has HPV infection, so this we say that this is of this patient. This is a patient in ASCOS, atypical squamous cells, high grade squamous cannot be excluded. So, and she is HPV positive. So this is a group of patients. There is no link. This is an active screen. This is what I'm screening for. I'm screening to catch these type of patient. This patient, I will immediately perform LEAP. So if the LEAP confirm this is actually a high grade squamous intraepithelial lesion, then this patient is treated. Then I will follow her after 6 months to confirm the treatment. As we said first, this is not a one-time screening. Then I will, if the new cytology, the new pap smear after 6 months of treatment reveal that this patient is cured, then I will go put her back into the general population. You understand me? Is it clear?
Yeah, clear.
So if, for example, if I have a patient that immediate CIN risk is less than 4%, or a patient with HPV negative with LISL, then I re-examine within 1 year. I don't do any treatment.
Okay. Okay.
So there is difference between screening and management. Screening is for the general population. Once I find a patient with any of these positive results of no pathology or PEP, then this is a patient for either I will take her out from the screening cohort and put her in the treatment cohort. Either this treatment is a immediate leave or colposcopy or just strict follow-up, but this is not for the general population. The general population with has negative HPV and negative cytology. So I can tell her to come back within 5 years. In 5 years to repeat the HPV and the cytology. If the cytology of HPV is positive, then we change. Then we put her in the treatment cohort.
Okay,
Okay,
clear.
I think it's clear. Clear, Dr. Wael?
Thank you.
Okay, thank you, Dr. Ashraf. I think we should come to an end of this very, very interesting lecture. Thank you, Dr. Ashraf, for this effort. Really, really, really a very, very, very nice lecture, and it will be a very big bang for the questions for the for the end of this module. Of
I hope they don't hate me for it.
no, 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 they will not. Yeah, they are all here are very impressed, really. Thank you, Dr. Ashraf, and
thank you. It's an honor to be here
now, and we'll see you all next week for the imaging modalities in cervical cancer with Dr. Basma Al-Ged, inshallah, next Wednesday evening. Okay, see you.
Thank you.
Bye.